Dr. Bennett is here in person. Okay, fantastic. That's odd. I'm throwing my book now.
The only thing better than hearing you once is hearing you
See, got these fancy marks.
Hey, it's a new system. We got issues that we have to work through, okay? So. And just for clarity, the whole system is not completely installed yet. And so there's gonna be better functioning as we move forward.
I just hope that we don't have to listen to me twice the whole meeting as well. All right. Morning, Dr. Bennett, welcome. I will turn the floor over to you and you can tell the executive committee why you're here today.
Yeah, we're trying to get our nurse practitioner approved by the state board so that we can practice medicine in the way that we would prefer and have our nurse practitioners cover practices and have them available for calls at night as a first call, and then have the cardiology physicians available as second for emergencies.
Yeah, so can you give us a little bit of background just on what your practice is like, how it works, and why a waiver or an exception is being requested?
Well, we have 7 cardiology physicians that are practicing at Anderson's Regional Medical Center in Meridian, Mississippi. And we're part of a bigger group of cardiologists who, the Cardiovascular Institute of the South, who manage our practice and have available to us a virtual care center that's available 24 hours a day, so that they are available when we are not in the hospital physically to cover our practice for routine minor things that come up at night. And these nurse practitioners that are available are working shifts, and they cover more than our practice. They cover in the state of Louisiana and our practice in Mississippi. And we need to have that coverage in order to manage our practice appropriately.
And so the waiver request, the waiver request is about the 75-mile rule for extended mileage. Is
Right.
that? And so what's the geography of that? Did I miss that?
You mean where is the
Yeah.
VCC? The VCC is in Lafayette, Louisiana,
Okay.
connected fully to our office management system and our healthcare records at the hospital electronically. So they're available and can see all of the information that we see and are aware of patient issues and communicating with nurses on the floor. And then if there's a physical need to come see a patient, obviously they call us and we are available to our patients to see them in the event that they need to be seen.
So then the NP group, are those the people that are on site, or are those the people who are somewhere else?
The NP group is in Louisiana.
That's okay. I just wanted to make sure
Yeah.
I was getting the who's where.
Right.
All right. So the issue is that they would be responding to calls that may happen in the hospital in the area where you all are located, but may not be physically available to, or at least to give you overnight coverage or some, to be your first call overnight.
Right.
Okay.
And they frequently call us and communicate with us and confer with us about situations that are going to require someone actively involved physically, directly with the patient.
And are these people that you already have a relationship with, or is this just a group, a hub that you guys have the ability to contract with? And are these nurse practitioners that you know personally and have a relationship with, or are they just a group that provides the service?
They provide our service for us. I know many of them, but I don't know all of them.
All these nurse practitioners are licensed in Mississippi.
Yes,
Okay, and you understand the collaborative rules for overseeing a nurse practitioner. So how are you gonna perform the chart checks for, when they do take care of patients? How are you gonna do the quarterly reviews with the nurse practitioners? What's your logistics plan as far as all that goes?
I don't have a logistics plan. I have a group of people who manage my practice for me. And they're more than happy to answer that question for you. But I don't have a logistics plan myself personally.
And I'm asking the questions so that the
Yeah.
executive committee can have the
Sure.
information, sir.
Whatever you need to do.
So, I see that there are a couple of other individuals who are listed with you. I think it's, Ryan Eber, depending on if he's in Louisiana, and Marcus Monte, perhaps. Okay. So are those the individuals who might be able to
Yes.
respond to those questions? Gentlemen, would you like to have an opportunity to speak?
Sure. So I'm Ryan Aber. I'm the CEO of Cardiovascular Institute of the South. So the group, so the 7 physicians that are in Meridian, Mississippi are part of our organization. We are a group of 68 cardiologists that cover Louisiana, Mississippi, and then we have actually an extension practice in Illinois. And then we also employ about 54 nurse practitioners in this. The design of the virtual care center in Lafayette, Louisiana was actually based off of the principle to reduce physician burnout. So by creating the opportunity of having the first call, where the call goes into a nurse practitioner that's dedicated to the evening. Basically, they're employed to work from 6 p.m. to 6 a.m. But what they also have is a collaboration. So they are all in collaboration agreement with our physicians. So they have collaborative agreements with Dr. Bennett and all of his physicians. They're Mississippi licensed. And they also have access to the hospital EHR. So there's a handoff that takes place where the nurse practitioner rounding team that works during the day that supports Dr. Bennett and his team have the ability to communicate with the virtual care center nurse practitioners. And then from there, so now you have the continuation of care opportunity. In the event that there's a call, the nurse practitioner that's awake at night basically receives the call, gets into the EHR system. If it's a non-acute related event, something non-emergent that requires not a heart attack or something that new onset of shortness of breath, they take the opportunity to go ahead and address it. It may be, patients experiencing slight pain and needs pain medicine for management. So anything within the scope of the practice of the nurse practitioner is done. From a collaboration agreement, so we meet on a monthly basis with the physicians, which we have a routine meeting. So what's going to take place from there, and it's a great question that you are asking, is that we will have a follow-up to basically if there's any disruptions, any discrepancies. It's a Zoom because we work in a virtual concept with that team. Is there any concerns? Is there anything we need to address? We need to reevaluate. That point, when they are able to collaborate and have that particular meeting, they're able to address any concerns. The principle of this is really what is better to have a nurse practitioner that's in the Meridian market that has worked all day and is in bed sleeping, get the phone call, or somebody that's awake and is able to get the first phone call and address it. We've routinely done this throughout the state of Louisiana. We've, like to extend this and continue to provide service in the Mississippi market under this with the exception. So that is the purpose behind this whole, us approaching y'all. Again, it's to mainly focus on allowing Dr. Bennett in the group to continue to focus on enhancement in care and reduce the burnout issue that we know is occurring. It's a common theme in interventional cardiologists.
So my next question for you is, do you do OBGYN too? I'm just- Just kidding, as a person who gets the phone calls at night. All right, so thank you very much. That was actually quite informative. And so I guess my next question then is, Dr. Bennett, while you do have people that manage practices for you, I think it's really important, and the point that that Dr. Cleveland brought out is that this responsibility, though, if this happens, if this is approved, that responsibility falls under you. And so
Correct.
the people who are the managers and the coordinators and all of those things don't matter. This ends up being attached to a responsibility of you as a licensee and also the other colleagues that you have in your practice that are going to be a part of this. So those individuals are the ones who are kind of on the line or on the hook for
Right.
the responsibilities of the rules and regs and making sure that you're kind of in compliance for that. So I love the fact that the administrative component can be handled by another person, but ultimately
Of
the
course.
carrying out of this is going to fall to you. And I
Right.
just think that that's like in fairness to you, that needs to be stated in advance so that you're aware of that. Any questions from anybody else on the committee? Don't everybody speak at once.
I have a question. I'm Dr. Renee Dotson from Greenville, Mississippi. When you're doing your monthly follow-up, essentially your M&Ms, how are problems there addressed? If they're, I mean, how do you maintain the quality of the nurse practitioners that are working for you? Because they're not physically with you. They're licensed in Mississippi, but they live in Louisiana. And that has been approved by the nursing board here?
I'd have to ask my administrative people.
Yes, so we are licensed within Mississippi from the State Board of Nursing as well. To point out, we are obviously treating patients within Mississippi from Louisiana. So the patients are within Mississippi. From the monthly checks, and we've lined this out in our protocol that you guys have requested for the request of the board and the rules and regulations. So this is all lined out as far as for how we will address these. If it's not my mistake, we can do it quarterly. We can do it as much as monthly as well. And the ideal is that we can either do it via Zoom or in person. And routinely, I'm present and I'm a nurse practitioner as well with these physicians in Mississippi and meeting up with them either at least monthly and minimally quarterly. But we are also Zooming with all of the nurse practitioners within Louisiana to go over the 20% or 10%, whichever is less, of the charts that they review, as well as the physicians are integral in the patient care that we're supporting and supporting for the physicians. So on a daily basis, they are seeing what we're doing. And so those particular patients that we're reviewing are addressing and are managing, the physicians are part of. So they're seeing what we're doing on a daily basis. So it's not like we're treating the patient without the physician involvement routinely from one day to the next. I hope that answers your question. If not, I can elaborate further.
These are patients that we're actively caring for. So we're seeing the patients in the hospital on a daily basis. And we do see and we understand what the nurse practitioners have done overnight. And we collaborate with them related to what the decisions they made and whether we feel like what they did was appropriate, if that answers your question.
Okay, so you flip the paradigm, is actually the nurse practitioner is actually away from the patient and you're actually there.
Right.
So how do you align? I mean, I'm looking at just your PI and your quality improvement. I mean, you can see what you do. You see what the nurse practitioners who take care of your patients do, right? So if there are any issues with that, how do you address that as opposed to just reassigning that nurse practitioner to another doctor and not? I mean, how do you ensure that quality is maintained?
Right. Well, we're communicating with our leadership and making sure that what the nurse practitioners are doing overnight is appropriate for what our patients need. And that happens on a daily basis. And we reassess, and if we have to, we make sure that they are following the standards of practice that we feel like are appropriate for what they're being confronted with overnight.
And my next question is, the nursing board here has signed off on this agreement. Are they aware that the nurse practitioners under this agreement are living in Louisiana and actually taking calls in Mississippi?
So again, yes, we are licensed within Mississippi and they're aware that our location is within Louisiana.
And they know that those nurses are practicing in Mississippi?
And I think what Dr. Dodson's trying to ask is, have the nurse practitioners filed their collaboration agreements with the Board of Nursing?
Yes.
The collaboration agreements have been completed. But I want to further go, so the quality piece is, just to add on what Marcus says. By the way, Marcus is our nurse practitioner, but he's also the head of our virtual care center program. So he is the primary driver of the initiative, the quality and everything that's centered, working in collaboration with our physicians. And the principal reason we have him here. But the fact that really this is a repetitive process where the docs constantly have a handoff. So it's really to create the dynamic where the nurse practitioner that's on call at night is able to provide, again, non-acute related care. And then in the morning, when the team comes that supports Dr. Bennett and his partners in Meridian, they also have the nurse practitioners that come in. So there's a consistent handoff. So if there's any discrepancies, we immediately become aware. We have our AHR, we track quality parameters across the board on a routine basis, just to evaluate where we are from and if there's any opportunities. If there's a discrepancy, we're going to know about it, but it's going to be an immediate address. So the resource that Dr. Bennett has is actually Marcus, so that if there was a discrepancy or a challenge in the night, he becomes immediately aware and it becomes a topic of discussion for the next logistic meeting. But there's also an immediate address with it, since he actually oversees the nurse practitioners providing the care in the virtual concept.
Do you have any, I'm sorry, I got distracted looking at, one of the things on the protocol. So is there a way, are these, patient calls flagged so that when you guys come in around in the morning, you know who the people are who had calls that have gone in overnight to the virtual call center?
You mean review every call that was
No, I'm
made?
just saying, is there a way that it's marked so that you know that when you come in the morning, that this is a patient who had, maybe there are 2 calls that went to the virtual call center. And I get that maybe you guys are getting calls for Miss Jones has a backache and she get Tylenol and
She
you
needs
guys get a
Maalox,
chance to say, yeah.
like, I don't
So
know that all the time.
So is there some kind of way that you, because if there's a wide umbrella of phone calls, and I don't think my expectation is that in the morning you have to know that somebody needed Maalox. That's not the point. But I just am thinking, you know, the difference between a non-acute versus something that might be of higher acuity or of greater
Absolutely.
clinical
Oh,
concern.
yes.
You guys have a process where those are flagged, or those phone
Frequently, I get
calls?
phone calls from nurse practitioners.
Okay.
Who are reviewing the chart, and a patient has a 10B run of ventricular tachycardia or something like that. They call me. And so, you know, there are open lines of communication that are used very frequently.
Also take it a step further as well. You add to that. So yes, we do have software that we can track, you know, whatever calls we get. We are documenting for the handoff as well for in the morning. So we're having conversations with the MDs if need be and when it's needed, as well as the nurse practitioners that are coming on for the next day to collaborate with, as well as communicate with, to be able to make sure that the patients that we're getting called on overnight, maybe it's 7 p.m. at night, that they are aware that this occurred on Miss Jones at this time. For that reason, we're documenting both in the EHR of the hospital, if that's where it needs to be, as well as in our potential own EHR. and then the software that we assist with communication to have that communication travel from one team to the next as well, for written documentation, because not everything's going to be written in the EHR or needs to be. As well as tracking for quality and insurance purposes, that whenever we do have our monthly or quarterly meetings with our physicians, that we can review those charts particularly, and if anything, needs to change because of that or for reasons of that, that those changes are made, whatever needs to happen.
Thank you. Any other questions? Okay.
And how long has the virtual call center been in effect?
So 2018 is really when we really took effect, from a call standpoint, from a remote location, from a centralized location for call purposes. We've been doing it in Louisiana in this way for quite some time, and has worked extremely well for us, especially for our hospital partners and our physicians alike, to be able to assist patient care overnight. Obviously, we know that care is not able to be provided in most locations 24/7, especially valuable with the acuity of cardiology and assisting the ER physicians as well as the nurses on the floor to provide up to date, up to the minute, up to the second reassurance that we're available. We can, like Ryan had mentioned, have the EHRs of both facilities, our records, as well as the hospital's records, and help make the ER physician's life a little bit easier and make treatment plans for those patients quicker, rather than waiting for the morning in most usual fashions that
I think just one more thing to follow up on that piece is that beyond the physician, beyond the fact that it's the 7 years, what we have seen is our physician satisfaction. We get some smiles rather than people tired and not feeling well in the mornings. So I'm a cardiovascular technologist. I've done the cath lab for many years. As these gentlemen get called out, if we can reduce the number of calls they're getting at night, it just improves the ability to provide the enhanced care during the day hours as well, which has been the principle behind this. And we've seen a lot of great success with it. Thank you for taking this into consideration.
Thank you.
Anything else?
Madam, Madam President,
Yes.
hey, my name is Tom Joyner and I have a question or two. I'm sorry about my hoarseness. Dr. Bennett, your practice is located where?
In Meridian, Mississippi.
Okay, and Lafayette, Louisiana is where the nurse practitioner is going to be available. Is that correct?
She's receiving phone calls about patient issues after hours, basically, yes.
I understand. Now, we know she's licensed through Mississippi Board of Nursing. And I've heard this in the questions before. I just want to make sure this protocol and an explanation of how this works has been presented to the Board of Nursing and they have approved it, correct?
That's my understanding, yes.
Now, that I hope is my understanding too. Did you bring any documentation to that effect?
I would have to refer that to my,
we can present that to the board as well. I have them, I just don't have them in here with me at this moment.
You don't have any with you for this meeting?
I have them for today. I just don't have them in this building or right this second.
That's something we can verify.
Yeah.
Jonathan's going to call the Board of Nursing now.
Okay. Okay, that's what I wanted to know. I wanted to make sure this wasn't just a nurse practitioner that was registered versus a protocol that was approved.
And Tom, if you, in the EC packet that was sent, the documentation that we have in the binders is also available to you in that email. And it shows the actual outline protocol as well as the request and the license information that includes the NPs and other information. So it's there for us to see, but the documentation or the verification piece we can do pretty easily.
Okay, I'm good with that.
All right.
And I do want to elaborate further as far as for the Board of Nursing of Mississippi. So the nurse practitioner licensing and our address of where we practice, we have the Meridian practice. So we are actually physically have our address located within Meridian practice because that's part of our total of CIS. So with that being said, I want to make sure that, I guess that point is clear, that the nurse practitioner's practice address is within Meridian because that's actually where we're managing the patients.
So that's a little different than, look, and I'm going back a couple of years when I sat on the Board of Nursing. I think the goal would be the physical location as opposed to the practice that you're assisting. Because the impression, if you use the place where the patients are being seen and you are not physically there, then how can you tell the difference between your nurse practitioners being on site and those people who are doing things remotely? So that may be an administrative detail that might need to be clarified. But I do appreciate you sharing that because that may, I don't know that it would necessarily make a difference with the Board of Nursing, but at least based on what I remember, and Dr. Dotson can tell me because she's on the Board of Nursing now. I believe that at least the regulations, or at least the perception, is that you should have your physical location is what they want and not where the patients are actually being seen. But you can make the distinction that patients are being seen at a certain location, but you also need to say where you are, because without that, then there's no difference. Nobody would know that you're in Lafayette as opposed to being actually in Meridian.
And to add, like Dr. Dotson had mentioned, the flipping of the paradigm wasn't intentional. I think it's just.
Oh, no, I think it was just I think that was just her she just was making an observation, not at all. So yeah, are we ready to entertain a motion? All right, I'm ready. Let me say that again. I'm ready to entertain a motion. If y'all are ready to. present. I make a motion to close the meeting.
I'll second.
All right, so it's been moved and properly seconded that we close the meeting to consider whether to enter an executive session. All in favor?
Uh,
That sounds unanimous. So I want to ask about those who are opposed or abstain. So we will close the meeting.
Stop it, Roxy. Yeah, I can't. Weird.
All right, we are back in open session and our secretary, Dr. Joyner, is going to give the results of executive session.
All right, this is Dr. Tom Joyner, the secretary. The executive committee of the Mississippi State Board of Medical Licensure has met and has voted to table the discussion of this item until a further session of the board is scheduled.
So it'll be to our next executive committee meeting. And we just are gonna try to gather some more information. If you have any other questions, please feel free to reach out to Dr. Cleveland in the interim. Thank you guys so much for being here and for your request. And I think it was just the feeling of the executive committee. We needed a little bit more time to gather more information before we made a final decision. Thank you. Yes, please.
So if it helps in any format, is there any specific information that we're able to supply? Will we be receiving any feedback? I'm sorry.
And after today and we get through our board meetings and all that, y'all can get in touch with me and I'll give you the information you need to provide us. And then there's some other homework that I need to do on the back end to make sure that we're in agreement with the Board of Nursing on all this kind of stuff as well.
Okay.
So there's a laundry list of things, but if you'll just get in touch with me later.
Yes, sir.
We'll
And
handle
that's,
that.
and to get in touch with you is going through Jonathan. Just want to
Yeah,
make sure.
that'd probably be the most, since you're familiar with that method, that'll probably be the best way to do it.
All right, perfect. Well, thank you again for the opportunity to come, and we hope that we're able to address all your concerns if there y'all may have. All right. Okay.
And thanks, we appreciate you taking the time to be here in person too. Thank you. So procedurally, if I could just take a moment, we have a number of guests who are joining us today via Zoom. And so I'm going to try to do this in a way that makes sense. I would like to have all of the people who are joining us by Zoom today to just state your name for the record. And I'm going to, so that everybody doesn't speak at once or fail to speak at once. Gerard, can you help me just by saying who the people are that you see so that those individuals can introduce themselves? So there's somebody that's labeled Steph, has on a green scrub shirt, but you're muted. So if you could unmute your microphone.
I'm Frank Giddon.
Okay, Dr. Giddon, thank you. Melton, Pamela Melton.
Michael Christie, OBGYN in Ocean Springs, Mississippi.
Dr. Abraham.
I'm Dr. Matthew Abraham with Skylink Medical.
And is Nikki LeGrew, is that what it says?
Hi, I'm Nikki LeGrew, physician assistant with Skylink Medical.
All right. And is there anyone else? Oh, Dr. Joyner, we've already identified.
I am Dr. Tom Joyner. I'm a family practitioner that on the Board of Medical Licensure. I would be sitting next to Dr. Owens if I could be there.
I've been keeping your seat warm, buddy.
Thank you.
And I think, so if there's anyone else who's on the Zoom that has not yet identified yourself, please speak now or forever hold your peace. All right, thank you guys for that little administrative diversion. And so we will hop back on the agenda and move to the appearance by Dr. Timothy Callahan.
Hi, everybody. Tim Callahan.
Dr. Callahan, tell us why you're here to see us today.
Yes, I'm appealing for a waiver to continue collaborating with 3 nurse practitioner groups that I've collaborated with for many years. Basic story, I know you have 1,000 things to do, is I've practiced in Tunica forever due to the economy. I was their county doc. They laid me off. So I couldn't find a job in Tunica, and everyone knows it's the top of the state, very rural, so there were no jobs. So I went across the border into Memphis, and I found a job working for Blue Cross. So I'm across the border. My collaborations are in DeSoto County. I'm about 19 miles from one clinic, 12 from another, and about the same from the third. They're all right near my house. I live in DeSoto County. I live in South Haven. 2 of the collaborations are in South Haven. One is 6-7 miles down the road in Olive Branch. I've worked for them forever. One clinic, they've been friends of mine for years. I'm cannabis certified, so they treat cannabis patients. I go by 2 of their clinics to see patients who are under the age where the NPs could see them by themselves. That's about the story. So I know it sounds very awkward because I'm in another state, but I'm a Mississippi, DeSoto County resident, longtime practitioner there and practicing for Blue Cross. Hope someday to come back and possibly, as mentioned, Dr. Cleveland, hoping in some time I could come back and work for one of the NPs as they are opening a bigger clinic in Hernando, and they would need a family doc. I'm a family doc. So that would be my hope. Long-term, short-term, throwing myself before the mercy of the court and knowing at least I can leave grabbing some chocolate out the door, but was hoping that there could be a waiver. I stay in close communication in that I go to Crystal Healy's office, Inspiring Health. I go to her house. We sign collaborations at her house. She's 4 miles down the road. Mid-South Integrative, I'll actually be there tomorrow. We certify some cannabis patients. They're actually my doc because they live I'm right down the road. And actually yesterday I was at DeSoto Family Care's Olive Branch Clinic, and Monday I was at their South Haven clinic. So then I'm a cell phone away, and whenever they need stuff signed that an MD has to sign, whether it's medical supplies or something, so they either fax it to me or on the way into work. I start at 9 in Memphis, they're open at 8, so I go by and sign stuff. So it sounds crazy to appeal for a waiver when I'm technically in another state, but I live right near them, close to them, know them, and person a cell phone away if there's a problem, and most of the time they're very smart. If they send me what's the question, I type on up to date and I pretend like I'm an expert in high-tech endocrinology, and I go, yeah, I probably would be doing this and this and this, and they go, wow, man, you're so smart, and I go, to date, yeah. So, like all of us, we use references, so that's my humble appeal.
So, Dr. Callahan, you are asking, your waiver request is based on this 20/80 hour rule because you don't really have practice within Mississippi border. But can you tell us just really quickly about your actual practice and what you're doing with Blue Cross?
Yeah, family doc, I work for a place called Blue Cross Sanitas. It's a company. Blue Cross has, they're half owners, so they try to get all their Blue Cross people to come through to get annual physicals and hoping to identify them for their conditions so they get managed better, so they don't get hit with big bills, from the hospital because they're out of control. We find out, their sugar's super high or their pressure's super high. So it's a very basic family. Well, it's not family. It's just a general practice. Diabetes, hypertension, lipids, the big three. And we try to get folks to come in, keep their annuals, come every 3 months, basic labs, nag them, to try to do better with their blood pressure, sugar, and lipids. It's pretty straightforward practice for Blue Cross. So that's our basic thing. In terms of I can never meet the 8 to 20 rule. I am there probably an hour, and I'll be there tomorrow at 7 at one clinic. So I'd be there an hour and a half tomorrow, but I can never make the hour rules. So that's why it's a Hail Mary pass, as I mentioned before. Just seeing if there is any way to continue.
And can I just say, I appreciated your letter. It was, it really helped to fill in. Sometimes when we get these requests, we don't really have any idea of what people's practice are like and what they're doing and why. And you laid it all out so beautifully. It really kind of took away most of the questions that I would have had for you.
Oh, it was me. It wasn't AI. Everybody's doing it. I don't think they got up to that level of sophistication to.
No, it was really very helpful, because it did kind of preempt a lot of the questions that we probably would have had to ask it just to see it written out. It helped to have an understanding of, what you actually are doing and what it looks like. Any questions from the rest of the executive committee? Hearing none. Dr. Joyner? Question?
No,
All right, well, at this point, I'll entertain a motion.
I move that we exit this executive committee meeting to enter into, well, just exit,
Close the meeting.
close the meeting.
Okay, so so there's a motion made by Dr. Joyner to close the meeting to consider whether to enter into executive session, which has been seconded by Dr. Dotson. All in favor? Any opposed, any abstentions? No. Hearing none. The meeting's closed. Okay, Dr. Joyner, will, give the decision, from executive session.
Thank you, Madam President. The Executive Committee of the Mississippi State Board of Medical Licensure has met in closed session and has voted to approve your request for a waiver. Congratulations.
Thank you all very much.
You can still have some chocolates if you want.
Yes.
Celebrate the sonic shake on the way home. We're for insulin. Thank you all.
Thanks, Dr. Callahan. All right, keeping on the agenda, I think we are now going to move to one of our virtual participants and hear from Dr. Gedon. I'll give you a second to unmute.
Okay. Can you hear me?
We can hear you. And there is, and so, and it's my understanding that Dr. Christie is here with you, correct?
Correct.
Yes.
Okay, all right. So Dr. Gedon, why don't you tell the executive committee about your request?
It's actually, let Dr. Christie can do that better than I can. I'm not going to be the guy that's covering for him.
Would you like me to? Would
Yes.
you like me to speak and give the request?
Absolutely.
Okay, I mean, this spurned from the fact that I have some unfortunate circumstances going on. I've been in practice on the Gulf Coast for 24 years, mostly solo practice. I've had some, having said that, recently my partner went out on a permanent medical leave, and my wife unfortunately has spot and bead breast cancer, and now she has a horrible bone marrow cancer for which she's getting treated at MD Anderson in Phoenix. So I was very fortunate to, while I was looking for some coverage, meet Dr. Gedon, and we right away, he seemed to be a great guy and a great doctor, and he covered my practice about 5 or 6 weeks ago, and we struck up a nice professional friendship. And then I started thinking, okay, I've been serving my community for 24 years, and I want to be able to keep serving the community. And the community is short on OBGYNs, like a lot of smaller towns. And so, having said that, I know that I'm likely going to have to take a leave of absence at some point in the next 2, 3, 4 months to go and be with my wife while she's getting treatment in MD Anderson, Phoenix. So then I started thinking about how I could keep my practice going if I do need to take an extended leave of absence, which I'm pretty sure I will have to do that. So in order to, rather than close my practice down, I was thinking about ways to continue serving the community. And that's when I met Dr. Gedon at the same time, I asked if he'd be willing to be a collaborator for my practice. And then we contacted the board and asked about because we understood there was a 75-mile rule, but as far as having a collaborator collaborate for a practice. So if my nurse practitioners were seeing patients, then when we contacted the board, they talked about the fact that it's not rare that people have a collaborating doctor who's more than 75 miles away. So I asked Dr. Gedon, and he seems to be a great guy, and he was gracious enough to agree to be the collaborating doctor for my practice if I were to have to take a extended leave of absence, which I likely will. So that's really the long and the short of the request. Mainly, about the 75-mile waiver to have an OBGYN who practices in Mississippi be a collaborator for my practice.
So, first of all, I'm just going to say that my heart goes out to you and your family for what you're going through.
Thank you.
And our community of obstetricians and gynecologists in this state is small. And I just, as one of your professional colleagues and also just as a fellow physician, fellow human, I just hope that this all works out for you.
I appreciate that.
No, absolutely. And Dr. Gedon, I've known you for how long? And I never knew your first name was Duncan. I'm gonna leave that on.
Well, that was my mother's doing.
Well, but it's good that you two met each other, because you guys are very similar situated. Dr. Gedon has a really long practice, and he's kind of been a lone wolf hanging out, doing his thing, in a rural area in Mississippi for a long time.
Right.
If your patient's getting a pickle, he can hop in his plane and fly over there to help him out.
Right.
No, but, any questions at all, from the executive committee? While Owens is over here just playing around with a couple of people who she has some peripheral knowledge of. Dr. Joyner, any questions?
No, ma'am.
All right, so, hearing no questions at this time, I'll entertain a motion.
Well, could I just say, and the other, I just wanted to add, if I may add something.
Absolutely.
I did check with, because I thought, okay, if I do take a leave of absence, if somebody has a postoperative complication or something of that sort, like what would I do? And if I was leaving and, you know, they came through, I did contact Dr. Finan, the well-known, very elite GYN oncologist who everyone probably knows. I mean, he moved his practice to Pascagoula, so I've referred a lot of patients to him over the last 20 something years. And now having him right on the Gulf Coast, I already asked him if there was a postoperative complication, would you see them? He said, of course I would. So that's just additional reassurance and coverage that the patients could be taken care of even locally if there was a problem. You know, even if it's just a mild infection or something, they needed something by a local physician. He said he would be happy to help as well. Although because he's not an obstetrician, I felt that I should have a practicing obstetrician gynecologist be my collaborator. But it's nice to know that someone local could handle an issue if somebody had a, you know, infection or something. So Dr. Finan, you know, said he would be available from that standpoint.
Thank you. Is there a motion?
I move that we,
Need your mic?
I move that we grant the extension for the extended mileage of collaboration for nurse practitioners.
So there is a motion that we approve or grant the exception.
Second.
All in favor?
Aye.
That sounds unanimous.
Aye.
All right. So gentlemen, thank you very much for taking time to be with us. Again, Dr. Christie, our hearts and prayers are with you and your family. And thank you for being so thorough to make sure that your patients are taken care of. Because even in the midst of all the things that you're going through, the fact that they are still top of mind and you are prioritizing their well-being by being this thorough is really remarkable.
Well, I appreciate everything that you just said. And I just wanted to add that, you know, went to medical school in Los Angeles. I'm from California, and I just said I want to come to small town America someplace and be a regular small town practicing OB/GYN. And I feel fortunate I came to the Mississippi Gulf Coast, and after 24 years of working a lot of hours and doing a lot of work, I wanted to be able to keep serving the community. I do feel very fortunate to meet Dr. Gedon. He's a great guy, and you know him, so you know he's a great guy. So another question we had is just if there's anything else we need to do, like approval wise because every time we ask, okay, what about the nursing board? Is there an issue they need to know about? And they're like, no, just talk to the medical board. But I don't know if there's anything else nursing board wise or anything else we need to do. And I appreciate the committee's approval. But, you know, I think that if I'm not in the state and the practice is still open, I do feel that, you know, there's going to be colleagues of mine that are asking questions like, why is his practice still running if he's not here? And so I want to make sure that I have everything squared away and all the proper things and paperwork in place. Is there other things we need to do to be thorough to make sure even with the nursing board, everything is complete?
Yeah.
Thank you for the question. If you'll contact Jonathan Dalton after today, so either tomorrow or Friday, he'll be able to walk you through the whole process.
Okay. Great. Thank you. Thank you very much.
Thank you, gentlemen.
Madam President, before
Yes.
Dr. Gidon leaves, I just want to say this, Frank, this is Paul Barnes, and I've known you since the 1970s, and I didn't know your name was Duncan either. But it's good to see you.
Good to see you, brother. Small world.
All right, moving on with the agenda, we have a Zoom appearance by Nikki LeGlue.
I'm here. Good morning. How are you?
Doing well. Good morning. Can you just tell the executive committee about your request and why you're here?
Sure. I'm a physician assistant practicing for Skylink Medical, which is a telehealth company focused on treating primarily obstructive sleep apnea. I work with Dr. Abraham, and I have for about 3 years within the state of Louisiana. So many of our patients are referred to us for management of their by other physicians, primarily cardiologists, usually our cardiology groups, for testing and management of their sleep patients. So they'll get referred over to Skylink. Dr. Abraham also treats these patients in real time with us. We use an electronic medical record that has like open communication between he and I at all times. So he's seeing patients at the same time as I am many times. And there's like a secure text link within our electronic medical record. So if there's any questions, we go back and forth in real time many of the days. So he reviews most of my charts now, and it's been working for us really well. It allows us to reach out and treat patients like rural health patients or patients that don't otherwise have access to treatment for their OSA. We're trying to move into, so some of our patients he's currently seeing patients within the state of of Mississippi also, and is just trying to have me be able to see patients with him within the state of Mississippi. It is on a telehealth platform. We're both located in Louisiana, but some of our patients that have been referred to us are in Mississippi.
And I'm happy to, oh, go ahead.
Yeah.
No, that's fine. I will give you an opportunity to speak in a moment. I did have one question because this is fascinating to me.
Sure.
Concept of telehealth and the application for obstructive sleep apnea, which to me is, I know that the diagnosis process is usually by a sleep study or something like that. You can screen them with symptoms, but how can you just help educate me on how this practice works? Because I know that, or at least most of the understanding that I have about OSA, a lot of that is so deeply rooted in your physical exam and, those kinds of things. So how exactly do you, how do you do that via telehealth?
Sure. So when they're originally referred, many of the patients will have a sleep study, either an in-lab if it is required, or a home sleep test. So a certified sleep specialist will read the original sleep study. So then I guess you may take you through a patient, kind of like an initial patient.
So, is it primarily algorithm based from the results of the sleep study, and then you can basically make a determination about what they need or where to start them with respect to whatever, device or aperture or whatever they may need?
Some of it is, yeah. We also do a physical exam. So all of our visits are video also. And so I do, when I see patients, I will do an initial physical assessment also. So we do, we'll have them, I'll look at neck girth, I'll look at their upper airway by having them open their mouth, turn from side to side, things like that, just to kind of see their Mallampally score, how their tongue overlies in their airway, how large their airway is. So there is an aspect of physical exam that we do assess and take into consideration with treatment also.
Dr. Abraham, I can see you like,
Yeah.
you're trying to say something, please.
Yeah, no, well, basically,
Please.
as of right now, the initial visits are handled by the physicians, the doctors themselves, which is me and another physician. I am training Nikki to do the initial evaluations. But basically, there's some basic questions that are asked through these patients, whether it be the basic questions of snoring, breathing irregularities, fragmentation of sleep, but they are all questioned in detail. The physical exam, which is actually for sleep medicine, is more of a visual physical exam, which is really adequate to look at the airway, to see the depth of the crowding of the back of the throat, the large tongue. But to be honest with you, the most important thing with the patients is education. And that's really what this is all focused about on these initial evaluations, education with the patient so they understand why they're even getting a test. If I see a patient first, they don't, which I actually prefer, we actually educate before they get any kind of testing. If we feel it needs to be in lab, I use a local facility. If we feel a home study is adequate, we can do it at that point. But the physical exam for sleep medicine, and I've been doing this for 20 years, I can tell you the visual cues from the video calls are more than adequate. And looking at our response on the patient care and the ability to get access to people that can't get seen, it's done really well. And we get about a 70% success rate with initiation of treatment with CPAP, which is better than most of my physical clinics where I've operated. So Nikki has been mostly on follow-ups. She does do some new patients, but not many yet, but that will be trained with them. But I definitely need help on that back end with them, which she's done really well with. So physical exam wise, most of what I need, we can get very easily with the video camera looking at the airway.
And just for the purposes of the executive committee's knowledge and understanding, what exactly is your training and background, Dr. Abraham? Sure.
My background is I'm board certified in family practice. I did a fellowship at Tulane for sleep and adult and pediatric sleep medicine. I'm boarded in the grandfathered in for the sleep medicine board, and I also have the new CAQH board for sleep medicine also. I was the director of Lourdes Comprehensive Sleep Center in Lafayette, Louisiana, and Crowley. I was also the director of the Lake Charles Memorial Hospital Sleep Center in Lake Charles. That one is no longer open. I'm still the director of Lourdes in Lafayette and Crowley as the director of the sleep center there. And then Skylink Medical, I built because I was having problems with access to patient care. We just couldn't get the patients overseen. We can't get them into the labs. We can't get them. The delays were extensive. That's why I built this company. It was all patient care focused. Our access to the rural communities and the poor patients and the Medicaid patients has been, for example, I take Medicaid, Medicare, everything because of the access issues. And we're getting more response and access than I've ever imagined. And we're getting better outcome. And I need these NPs and PAs that I train personally. I oversee them all personally inside the company. So no one is outside the company that works in this. We basically oversee them. I have another doctor that's partially involved right now. I'll have other sleep physicians in the near future. So the company is built around patient care and patient focus completely. The access and location of me and Nikki doesn't really make a difference in my oversight of the care. Everything is digital. We communicate regularly. I have an open door with all the clinicians I work with, and not just her, but others. And so the whole goal is when they're working, there's access to a physician if needed at all times.
And what's the difference in physical location between the two of you?
We're in the same city right now in Lafayette. So we're right by each other right now in Louisiana. But I do have clinicians that live 40 miles away, and I have other clinicians that I will be training even in other states that won't be an issue to oversee them. And we've done thousands of patients, and we actually kept the data to prove the outcome also. So we can show a 70% compliance rate, which is really high on anybody that initiates the treatment after they get the machine. And I've kept those records purposefully to show that the outcome is actually what the outcome is.
Questions from the executive committee?
Hey, this is this is Tom Joyner. You make the statement that y'all live right next to each other, and then you use the word right now, which means that your practice is evolving in some direction. what would that direction be? What are your goals for the future that may involve the parameters of our rules?
Well, this is a good question. I mean, the company's goals are very simplistic. The company's goals are patient care and outcome. Our goal is and nothing in this company is going to be done without oversight of the NPs and PAs inside our company. So our goals are to grow a little bit to get more access to patients. That's the goal. But as for oversight, that won't change. And as for the ability to communicate with the NPs and PAs through video calls and through Zoom calls, that won't change either. That's always going to be present. We'll always have access to the clinicians. Now, the distance between the two clinicians, it could be 1,000 miles or 100 miles. That has no relevance to me working with these clinicians and NPs and to train them and get them organized. And it hasn't had any implications in our outcome or treatment modalities. And so the location of my clinicians with me is not impacting the outcome or the oversight. I review most of these notes and I review actually the vast majority. And when at some point there'll be some less oversight as I trust the clinicians specifically, and so that depends. But as for oversight, the physical fact of the patient, if that nurse practitioner is 10 miles or 100 miles, has not had an impact on the outcome of my care of the patients.
Okay, so right now, like I said, you're right next door to each other. Your practice is located in your location, which I don't have a problem with. But then you use the words 100 miles or 1,000 miles. That bothers me. So are you planning on establishing satellite locations across Mississippi that would be outside the parameters of the protocol?
Well, this is where I'm confused. When you say the protocol, the thing is in Mississippi, we are here and we do have a little office in Mississippi, but the nurse practitioner happens to be next to me, but all of our communications are virtual. So whether that nurse practitioner is here or physically in Mississippi, that doesn't change my oversight of that patient care. And that's what I mean by that. So the fact that Nikki is here in Louisiana, we do everything virtually for the communication and the oversight.
Okay.
So if she lives here or in Mississippi is what I mean by that. If I had the NP that lived in Mississippi, which I would like, that still doesn't change my oversight of the care. Does that make more sense?
That makes more sense if I'm looking at it from your point of view. I'm looking at it from the board of licensure point of view.
Yes.
Are you familiar with the mileage requirements
The 70, yes, the 75 miles. And that becomes an issue because there's no way for us to have, now between me and Nikki here, we are within 75 miles. So if that works for Mississippi, well, that's good. But to me, and I won't go outside of what Mississippi allows, but in other locations, that mileage isn't the same requirement. I'm looking for Mississippi to help take care of the patients in Mississippi, though, right now.
I understand. So if you're in where are you located now? I'm sorry.
I happen to be in Lafayette, Louisiana, sir.
All right. So if you have a physician that wants to join your group and he's in Clarksdale or he's in Tupelo, how would you deal with that?
Well, the reality is, unless the board allows us permission to do that, we wouldn't allow them to come onto the company. It would depend on the board's requirements. In other words, that's why I'm asking the board to give us an exemption to do that. If not, I would have to see the patients myself.
Okay, that's what I wanted to know.
Oh yeah, I won't go outside the board. There's no way. No. I'm here to, that's why we're here.
Yep.
Dr. Abraham, you understand that if you were going to add additional practitioners, whether it be physicians or mid-level providers, that you would have to come back before the board and have additional protocols approved?
I'll do whatever y'all request. I have no issue with that whatsoever. I'm here to work with the state of Mississippi and to take care of the patients. So whatever y'all require, I'll be happy to do.
I think I have a question within like those. So yeah. All right. Any other questions from the executive committee? What? Well, Dr. Joyner.
I don't have any further questions, and if nobody else does, I'd make a motion that we go into executive session to consider this matter. Well, I make a motion that we close this meeting. Sorry.
It has been moved and properly seconded that we close the meeting to consider whether to enter into executive session. All in favor?
Uh,
All righty, thank you.
Thanks.
All right, the executive committee is, we're back in open session, and Dr. Joyner will report the decision from executive session. You're muted, Tom, so we can't hear you.
I'm sorry. Thank
Okay.
you. The Executive Committee of the Mississippi State Board of Medical Licensure has discussed this matter in executive session, excuse me, and has voted to approve your request for a waiver for the 2080 collaboration rule and for mileage for the practice of sleep medicine.
We appreciate that. Thank you.
Thank you so much, and thanks for your time this morning.
Thank you guys for appearing.
Absolutely. You'll have a great day.
Thank you.
Thank you again. Bye-bye.
Madam President, Ms. Hearing Officer, I just want to take this opportunity, next on the agenda is Dr. Shimoni, I believe I pronounced it right, and said that he is accompanied by his attorney, Mark Garriga.
All right, so Dr. Shimoni. And Mr. Garrigan.
Hello, everyone.
Hi.
Thank you for having me. I'm coming from Memphis, Tennessee, and I'm here to request a waiver for the fact that I don't have 3 years of postgraduate training in the ACGME approved program, and the fact that my step 1, 2, and 3 took me longer than 7 years, and all of that in order to get a license, medical license in the state of Mississippi. Talking about myself, I have my CV here if that needs to be given, if anyone wants. I am currently an associate professor in University of Tennessee in neurological surgery, in neurosurgery. I'm a pediatric neurosurgeon myself. I practice in Sam Murphy Clinic, but my main practice is really at La Bonheur Children's Hospital and St. Jude Research Children's Hospital. My main focus is epilepsy surgery and brain tumor or spinal cord tumor. And we take care of kids coming from pretty much all over the country and sometimes abroad. I have many patients coming from the state of Mississippi. And my main motivation to be here today and ask for it, because I am, part of my training was abroad. I was doing my medical school and my residency back in Tel Aviv in Israel, where I was born. And I did my fellowship here in Johns Hopkins in Florida. And then eventually stayed in the United States and practiced neurosurgery for 4 years as the director of pediatric neurosurgery in the Geisinger Health System in Pennsylvania, which is an ACGME approved program. I was a teaching faculty, and I had back then an assistant professor academic degree, as well as one that I still hold in Johns Hopkins University as an adjunct appointment. And then I moved here to Tennessee mainly to join the group at St. Jude, which is very close to my heart in terms of taking care of kids suffering from neuro-oncology or brain tumor or spinal cord tumor pathologies. Like I said, many of my patients come from Mississippi. It feels not good for me as a physician that someone that his kid just had surgery for a brain tumor or epilepsy surgery and needs to drive 4 hours, 5 hours to see me in clinic for 10, 15 minutes and go back. And I prefer, what I would like to have is the opportunity to open an outreach clinic or outreach clinics in Mississippi and to come closer to my patients and basically give them better service. We call the patient, not Zoom, not telehealth. We call the patient as courtesy to see how they're doing, but it's not the same like a real clinic visit. So I do like that. That's the reason I'm standing here and asking for this medical license. Beside that, I would be happy to answer any question.
So when you said that you have a lot of patients who come, are you, what exactly are your plans or what are you interested in doing, specifically in Mississippi?
Um, instead for the patients to drive all the way to East Memphis to come and see me before surgery, which is the better of the two options because they come to see me before surgery. We keep them in FedEx house for a day or two and they come for surgery. Some of them come to see me to discuss, for example, epilepsy surgery, and they go back home. I want to try and get closer to them, see them closer to their home, and basically get the compliance for follow-up, compliance for getting the treatment much higher than what it's currently. I have many patients that in a way lost to follow-up because it's too hard for them. It's too hard for them to come back. I can give you many examples. Patient after spasticity surgery that mom has 4 kids. She cannot drive to see me for 10 minutes and come back. So I would like to have something closer to them.
And one of the things that, while I do have quite a bit of information about your background and the letter that was submitted on your behalf and your request, you said you have a CV with you.
Yes.
Would you mind just providing us
Of course.
a copy of that? Great, thank you.
Thank you. That's several copies there.
They call it a CV, but for medical people, it's kind of like a biography, right? I mean,
Yeah.
so much of your life is poured into this stuff. And since you took the time to prepare it for us, I wanted to make sure everybody got a chance to see it. Any questions at all from the executive committee? Dr. Joyner, any questions?
Thank you.
No, ma'am, I don't have any at present. I do think we need to enter into executive session.
Just any other additional questions? And it hearing none, I will entertain a motion if there are no additional questions. I'm going to give people a couple of seconds to look over the CV if it generates any questions. And Dr. Shimoni, you made it seem like all you were doing was operating, but it looks like you've been publishing quite a bit as well.
Yeah, I do. Yeah.
Madam President, we're having the CV scan to be sent to Dr. Joyner.
Okay, fantastic. Tom, keep your eyes open in your email because we're going to send you a copy of this so you'll have an opportunity to see it as well.
Thank you.
All right. Is there a motion? Anybody? Can you give me your mic?
Sorry, I move that we close the meeting to go into executive session.
Second.
All right, it's been moved and properly seconded that we close the meeting to consider whether to go into executive session. All in favor?
Aye.
All right, thank you. I'll be right back. back in. We're back in open session. And Dr. Joyner will give the decision of the executive committee.
Thank you, Madam President. The Executive Committee of the Mississippi State Medical Association has met and discussed this matter, and we have voted to approve your request for a waiver as requested. Thank you.
That means grant you a license.
Thank you very much, everyone. I really appreciate it.
Absolutely.
For the
And-
record, that's medical board, not medical association.
Yes, sorry. I stand corrected.
Freudian slip. Yes, so thank you very much for your time today. And if you'll give me just, we're gonna conclude this meeting, and I would like to speak to you for just 1 second, Dr. Shimoni, after this is over. If that's okay. Thank you. All right.
Can we request just to postpone the start of the board meeting to 10:20 or so?
That works.
Okay.
Okay. Do we need to, is there a EC update or something we need to do? Remember, we got, all right.
Thank you. So during the months of May and June 2024, I continue to meet with the other health boards, both kind of in a social atmosphere where we can openly discuss issues that may pertain between the boards. But specifically between Board of Pharmacy and Board of Nursing and the Medical Board. I'm sure y'all are familiar now that we do joint investigations on different kinds of clinics. And so that still continues and works very well. I meet with our Physicians Health Program on a monthly basis to discuss participants. During this past 2 months, the May and June months, I met with 5 different licensees for regulatory compliance meetings. We attended the FSMB alternate licensing meeting put on, and then
By we, he means he and I.
yeah, Madam President and I attended an alternate licensing symposium. And we have already started our planning for the next legislative session, including making new drafts of our request and our bill to be presented to different legislatures. I'm already scheduling meetings with legislatures to discuss any issues they may have and trying to work out those differences way in advance of the session. As y'all know, we made a lot more progress this past year than we've made previously, but we still didn't get a bill through to the governor. And so that's always our goal.
Any questions for the executive director at this point? Hearing none, thank you, Ken, for all the work that you're doing. At this point, I think that is the end of all of our agenda items. So we can adjourn the executive committee meeting, and we will reconvene at 10:20 to start the